But I think the biggest thing is the lifestyle measures and really how to intervene with food, nutrition, how important exercise is, and how to be the go-between between the book and the patient and really try to kind of pick apart what's stopping them from being successful there. If we could stop having so many diabetics or heart patients, then we wouldn't have so many sick elderly people. But until we get that first preventative piece out of the way, we're not going to affect that at all. We can treat a diabetic once they're diabetic, but let's worry about not making them diabetic.
Welcome to Personalized by Vitamin Lab, the show where we dive deep into the world of personalization in healthcare. I'm your host, Dr. David Deiser. Please remember that the following discussion is for educational purposes only, and it's not intended to diagnose or treat any disease. Speak with your healthcare practitioner first before integrating anything that you learned today. Join us as we explore the remarkable stories, breakthroughs, and possibilities that come with the pursuit of personalized healthcare.
Welcome back to Personalized by Vitamin Lab. I'm your host, Dr. David Deiser. Thanks so much for tuning in. Today, I'm excited to introduce Jennifer Kosova, physician assistant and founder of Noble Family Medical in Beverly Hills, California. After completing her PA degree from NSU, Jennifer spent 2 years in orthopedic oncology surgery and 23 years in emergency medicine. Next up, she began fellowships in anti-aging and metabolic medicine, as well as functional medicine, where she began to hone her personalized approach to care. Today's podcast is a great one where we touch on personalization in bioidentical hormone replacement therapy and the impact that personalized medicine has had on Jen's own health. In her clinical practice, Jennifer is known for a collaborative, meticulous, holistic, and personalized approach to care. So naturally, she fits in great on our show. Please enjoy my conversation with Jennifer Kosova.
Welcome back to Personalized. I'm here with Jennifer Kosova. Nice to meet you, Jennifer.
Nice to meet you, David.
How are you doing today?
I'm doing great. It's a beautiful day here in California. Can't complain.
There you go. It's a beautiful day to talk about personalization in medicine. Come on, this is the best. It's my favorite thing to talk about. And you've got a really cool career going. You're a physician's assistant,
Yes.
a physician assistant, which I don't know much about. Could you please tell me a little bit more about this career, this pathway?
Absolutely. Yeah. Physician assistants are commonly referred to as mid-level providers. Nurse practitioners are also mid-level providers, and we're physician extenders. We are intended to bridge the gap of the glut in the medical system. There are only so many doctors and only so many nurses, and so physician assistant career was created kind of to help extend the doctor's scope without having to send more doctors to medical school because medical schools have become really difficult to get into, and some people end up just going into the PA field because they can't get into medical school. And then they find out that they actually get to spend more time with patients because they're, the ones that are kind of making up for the lack of time that the doctors have.
Right. Makes sense. Well, what's your career been like so far? Tell me about some of the things that you've been able to do in this career.
Yeah. So for the past 25 years, I've been in emergency medicine. Started out briefly doing some surgery in orthopedics and wandered into the ER of the hospital that I was operating in, and just really loved the intensity of the emergency room. The fact that you could kind of deal with, a brain injury one day and then a foot amputation the next day. And it was just a really cool, stimulating environment. And so once I started, I stayed. And it's been a great experience. I've learned so much because you kind of have to be a jack of all trades in the ER.
Yeah, for sure. Do you ever? Every day be super interesting.
Every day.
And if you like that kind of excitement, probably fun too.
Absolutely. Yeah. I'm one of those weird people that if I get a crazy case that comes in, I'm the first one to jump on it. Just love really getting the experience, even if it's something you haven't seen before. It's really valuable being in the ER as a PA because you're working side by side with your attending physicians. And so every case that might be a little bit scary or new, is ability to test your strengths and then learn a little bit more because you're just working side by side. And so it was a really empowering learning experience to have done that.
How do you go from doing that to working in functional medicine?
The crazy thing is it's completely opposite. but so much the same. In the ER, our job is to make a punch list of anything that whatever you're complaining about, anything that could kill you with that complaint. And if I can go through that list and cross everything out, I can let you go home and I'll let your doctor sort it out. And so, in the way that it's so different from functional medicine is we would get to ignore a lot of the chronic illnesses, right? I knew I was never going to cure a patient's diabetes, but I could treat their acute exacerbation. Or I might diagnose a lung cancer on an x-ray, but I'm not going to be, doing the chemotherapy. But the ways it's similar is that you apply that same punch list theory to your own life and to your own health and protecting your longevity. I make a list of everything that I have to worry about in the next decade, the decade after that. And then I use my time now to train for that and prepare for that, go through that punch list to make sure I'm addressing all those things. So the application of the medicine is the same, but the focus is so different.
Right. Yeah, that's a really good way of putting it. I like that. That's cool. What was the training like? Like, what'd you do to kind of make the transition?
Good question. There are so many things in functional medicine that get glossed over in regular medicine, right? In the traditional model, if there's not a drug already out there that treats it, chances are you don't know about it. You don't know the nutritional protocols or supplement protocols that can help somebody. So starting with the basics, I started a fellowship program with A4M. And the great part about that is they go right into endocrinology, cardiology, and within those subtopics of pathophysiology, they teach you lifestyle changes, nutritional therapies, supplement therapies that will help people avoid getting the illnesses that they need pharmacological treatments for. For instance, statins, right? There's so many people that are on statins now, and they're great. They help decrease cholesterol and, decrease your risk factors for cardiovascular disease. But they also create about 10 different micronutrient deficiencies. Well, if you're not supplementing somebody's CoQ10 or their B12, they're going to become deficient in this. They're not fueling their cells. And there are really no pharmacological agents that work at the cellular level to fuel your mitochondria to fix your own body. And so, I think learning how to apply measures that were never taught in school that are not pharmacological agents was really the best and first thing that I learned to help focus a career in functional medicine and preventative medicine, really.
Yeah, it's easy to get interested in preventative medicine when you see people so sick all the time for 25 years. And being in an emergency setting. Was that inspiring to you at all? Did that motivate you?
Oh, 100%. I think one of the last shifts I did in the ER before COVID started, I remembered being really impressed that I had a 61-year-old woman that I was trying to sit up in the bed to listen to her lungs. And she had such a hard time just sitting up for me to do the exam on her. I thought, wow, to be so deconditioned at that age, there were so many opportunities before she got to that point to help her. And I felt like the traditional medical system had really failed her in helping her, be stronger as a 61-year-old woman than she was. And that was really inspiring to me to start looking for ways to keep people out of the emergency room. And when COVID came, that was a great opportunity to start working one-on-one with people because so many people didn't come to the ER for things that needed to be treated. They stayed away until they were sick or dying. And so being able to see people over telehealth I did a lot of house calls during the pandemic. I was able to really understand the things that were missing in these people's medical interventions and provide them and watch my patients have successful outcomes because of that.
Oh, cool. Yeah, that would do it. Can we take that as a case, like just to get started about personalization? Really, like, let's say, in the setting you're in now, we're thinking about that person who's sort of 61, lack of strength, lack of conditioning. How can we personalize their care? What would be your kind of step-by-step process? What are those boxes that you want to check for that person?
Yeah, for sure. So I start out by doing really comprehensive blood panels on my patients. And, I think a lot of providers even don't understand that when you get a lab slip back on a patient for blood that you've ordered, and you look at the page, and you look at that right side of the page that says that, what the blood should be, the ranges that they should be between, those are not normals. Those are averages, right? And so, the lab they'll chop off the low 10% and the high 10% and just put the numbers that they're getting when they test humans. And if you think about it, the humans that are going to the lab to get their blood checked are sick people usually. I mean, some healthy people, but it's usually sick people. So right away, when we look at a lab panel, we know we have those ranges there that tell us the human ranges, but you need to know what end of the spectrum you should be on for each one of them, right? Like if that range is an A- to a D+, well, I'm normal. Does that mean I have a D+ or an A-?
Right.
And so I start by really going through each body system and looking at those numbers to see, are they at the right end of the range or the wrong end of the range? And, kind of like when you remodel a house and you put a piece of blue tape on all the stuff that needs fixing, that's what I do. I'll look and say, these lipids are too high. We need to address this. This TSH, might be considered normal, but it's way out of the range and I need to dial that in. Maybe this patient has a cortisol problem. And so I'll put my little blue stickies on all of these abnormalities, knowing that I need to dial patients into those ranges. And then I talk to the patient, spend a lot of time with them, and listen to what they're doing in their lifestyle that might be promoting these numbers to be on the wrong end of the range. Usually you can find a lot of problems within the way they're providing nutrition for themselves, the things that they're eating or the times that they're eating, the frequency. A lot of times you can find that patients are, sedentary, and just getting them walking and not sending them into the gym to work with a trainer right away, but working on the things that we know they'll do and it will gain momentum and enjoy success from. Those are really the first steps I do with people, and then the branching from that is very individualized based on the person.
Completely. Let's work our way toward that individualization. I've been teaching lab diagnostics for 5 years to nutritionists for a long time. And the key question I get, which I'm not the best at answering, is what are the optimals? What is the number for the person in front of us that we need to be shooting for? Can we pick a few? I'd love to hear your opinion. Really, this is more of an opinion piece. You may have some literature to back up certain things, but for most of these, it's opinion. Let's pick like a few of your favorite go-to labs, things you see on the panel all the time, and tell me about the optimals that you are shooting for.
Absolutely. Yeah. So LDLs are a big one when it comes to cholesterol. Unfortunately, in this country, we only really look at people's risk for the next 10 years out, right? So I'm 50. And so when my doctor looks at my LDLs and tries to decide whether or not I should be on a cholesterol medication, they're only going to look and say, well, you're not likely to have a heart attack before you're 60, Jennifer. So don't worry about this LDL of 120, which is what mine was before I started treating it. You don't have to worry about that. Well, it's just like saying, Jennifer, you're not going to retire until you're 70. So don't put any money in the bank, just spend it all. And so I think,
Great analogy, by the way.
yeah, right?
Yank. I just took that one. That's a goodie.
It's a stable. If you relate to money, usually people will pick up on that. The health is easier to ignore than their bank account.
Yeah, right.
So it's money in the bank to protect that number and to keep our arteries from being clogged up. Once I find plaque on you, that plaque is there. I mean, it's going to be there. So LDLs are a big one, and I see that overlooked a lot. The fasting glucose. The normal on the lab isn't going to trigger your doctor or the lab to mark it in red until it gets above 100. But we've done so many studies that show anything above an 86 when you're fasting, you shouldn't have that much glucose circulating in your bloodstream if you haven't eaten anything. Where is it coming from? It's because you're overfed the day before. You're storing it in your liver's overflowing. You're storing it in subcutaneous fat, and now it's showing up in your blood. So that's a number I think that really needs to be intervened on between 86 and 100, but nobody's talking about it till it gets to be over 100. Vitamin D is another one that's like, if you had your blood checked 10 years ago, you didn't get a vitamin D level done. Now they're starting to do it. Thank goodness. They're realizing it's an important micronutrient for hormones, for bone, for brain health, for immunity. I think COVID shined a light on that. But a lot of doctors are just aiming for the bare minimum. I have patients that come in, their number's 30, 33. Oh, my doctor said it's fine. I don't need a supplement. I would like my patients to be a little closer to 60. That's for, a lot of the studies on immunity and brain protection show it should be. Uric acid, same thing, hardly ever checked, but people are taking in so much fructose. with our food manufacturing, high fructose corn syrup is used. I mean, I could go on and on for days with labs.
Oh, this is great though.
Hormones.
Okay, let's unpack this. Let's unpack these 4 so far because I'm obsessed. Let's unpack these 4. We'll go back to LDL for a second. I'm not the best at converting between American units and Canadian units. It's more difficult for me, but I've got a sense of what the 120 means in our location. Often when we see things like that, when we see levels like that, we'll look at ApoB or LDL particles, small LDL particles, large LDL particles. Do you ever do any of those comprehensive lipidology assessments?
Absolutely, yeah. And that's part of the individualized approach, right? I have some patients I've drawn labs on. I could do a lipid panel initially, and their LDLs are 70. I don't need to do a big lipid workup on this patient. They've, triglycerides are normal, LDLs are good. ApoB is basically a reflection of all the load of the non-large particles. And so ApoA, ApoB, or an LDL, in my mind, I can get either one of those tests and know what I need to know. But yeah, when a patient has high LDLs, maybe high triglycerides, then they will really benefit from a full lipid panel where we actually count the particle numbers. Because really LDL is just the carrier molecule, right? It's not the cholesterol itself. People have been taught that that's their bad cholesterol. Unpacking that and explaining the nuance to a patient sometimes is a little bit too sciencey to grasp. So, but if somebody has an advanced lipid issue, then doing advanced screening and keeping an eye on those numbers while you're treating with either a statin or non-pharmacological therapy is really good for those particular patients.
Does it change your approach at all, knowing the particle number? We in Canada here, we do a lot of ApoB just because the cost is so low. And we're seeing the conventional system do it more and more often. I think maybe it's a better measure for us to be looking at. Can you give me some examples of how it may change your protocol to have LDL particle numbers versus just LDL cholesterol? It's difficult.
Particle numbers and size also matter.
Size
of the LDL. I use it more as a trajectory. Are we going up or are we going down with what we're doing? And so more as a guide for therapy. I mean, are you in trouble with a really high LDL particle number? Well, I don't know. Do you have plaque? How many more years do you have to live with that number? And really the actionable question is, what are we going to do about it? And is that going to work? Yeah. And so, some patients, I'll start just on Zetia or ezetimibe at first, if I'm going to use a pharmacological agent, if it's high enough to warrant that. And then I'll add in a statin slowly if I need that, a little bit at a time, and keep an eye, okay, how much further down does that bring the particle number? Where can I tap out on that to where I don't really put pressure on the glucose system, which I don't want them to have problems managed. I don't want to create a diabetic by overly aggressively treating a lipid panel. But yeah, to answer your question, shorter rather than longer, more as a trajectory measurement.
Trajectory. I like that. I've had 2 scenarios that I've been in. I look to you for advice. I've been 2 exactly the same scenarios where the small dense LDLs are right at the border, but the particle numbers are incredibly high and the large LDLs are elevated. In a scenario like that where the particle number's really high, but the small dense hasn't significantly crossed over the level, do we need to be less intense with our therapy in that scenario? Like, do you always go really, really low LDL? Like, do you shoot for super low levels of LDL particle, even though maybe the small dense hasn't crossed over so much?
I mean, I think if they have a high particle count to begin with, you should be aggressive about it.
You got to bring it down. Yeah.
Yeah, because I mean, there even the treatment sometimes can downregulate the creation of the carrier proteins, right? So you can still have a lot of particles, but not enough carrier proteins to carry them. We see that more with HDLs, right? Because HDLs are the ones that bring it back, to the liver to be disposed of. And so, sometimes we look at a low HDL and we know that the patient doesn't make enough of them. And we worry, well, are there enough carriers to carry all of these lipids back to the garbage dump? Conversely, could it mean that the patient has so little lipids or so few to transport back? That's why they have no carrier molecules. So really looking at the particle number is much more determinant of need for treatment than looking at the carrier protein that carries those particles.
I love that answer. I love that. That's why I like ApoB. That's exactly how I've approached it in these 2 cases and other cases that may be similar too. Do you have anything that's like new or, has some decent evidence that many of us haven't heard of for LDL suppression that's maybe not red yeast rice or, the conventional approaches? Like, do you have any new natural approaches that you could share with us?
I literally have a list of 16 different things that are supposedly, supposed to help the LDL levels, right? Statins only are one of them. And red yeast rice is a very common nutraceutical, I guess that's what you'd call it, that people have used for that. Garlic is another one. I don't think a lot of people know or utilize that garlic brand specifically.
It's very effective.
Mm-hmm. And you can buy that at the grocery store and season your food with that. That's always one that I think surprises people. The cocoa flavonoids, I think are an underutilized one on that list that have some good data behind it. And a cardiometabolic diet. I mean, the reality of it is you don't get any fuel in your body without you putting it in the tank. And so, just being cognizant of what types of fats we're taking in, what types of oils, how those oils break down, knowing your own fatty acid balance, right? I mean, we all know we should take omegas, but what omegas do you need? Do you need EPA? Do you need DHA? And what ratios of those are good for you? And what's your current balance, right? Do you have an omega index of 11? Well, you probably don't need a supplement then.
I agree with that. Yeah, I like that. Let's go into blood sugar a little bit. I mean, you took that as number 2, and I agree. It's got to be way up there, including inflammation. Like, we put blood sugar and inflammation kind of in the same sort of bucket. Tell me about your approach maybe to nutrition, exercise. Are you like glucose monitor for everyone, or are you keto diet, low carb? What's your approach to blood sugar management?
Yeah, so I use intermittent fasting a lot, with caution with menstruating and perimenopausal women specifically.
Fair, totally.
But when your body is fasting, it's an opportunity for your liver to empty out everything it's storing. And, that's what's glutting up the system. And so if you have an overabundance of glucose, emptying out your liver is a great tool at decreasing triglycerides and decreasing fasting glucose, also to improving your insulin sensitivity, right? And so if you can add on 3 hours before you go to bed at night of no calories, I think that's the biggest lever for people to really kind of empty their tank and be ready for the next day without, overfilling. That's probably my favorite measure.
I like that too.
An easy, like low-lying fruit thing. Adding on then an hour in the morning when they wake up, even if they have to do it slowly because they love their coffee or they can't go black on their coffee, then, 15-minute increments. Just wait 15 minutes to eat something, another 15 minutes to eat something. And then really protein-forward diet. I don't think people really understand the need to get a good solid, at least, at my age, 40 grams of protein in your first meal. And it has to be bioavailable protein. And so if you're taking pea protein instead of whey, that number might need to be 60 or 80 really to meet a threshold to start muscle synthesis. And as soon as people start doing that, they're going to crowd out all of those carbs and a lot of the fat that they would have eaten in their lunch meal because of the way they approach their first meal of the day. And so that has a compounding effect. And so that is that might be my favorite tool, actually.
You just gave me a tummy ache with 80 grams of pea protein in the morning. Oh my goodness. Yeah, but I hear you. It's so not bioavailable at all. I know. Well, comparing it to whey for sure.
Yeah, I feel bad for the vegans out there because they really have to chug down a lot of that stuff to make an impression on their muscles.
My wife's a vegan, and she has been since she was like 10. She's been doing a lot of amino acid therapy, just taking aminos, complex aminos, and doing quite well with it, like noticing muscle building and having, solid appetite control. My appetite is outrageous. Like, I used to be a really good faster, but recently I have had no capacity to fast, and I blamed it on NR, nicotinamide riboside, but I haven't been doing it for a year. My appetite is still incredibly high. But in the last couple of days, I've been thinking a lot about natural GLP-1 agonists, not agonists, but boosters, not agonists, increasers of GLP-1. And I found out there's like a little bit of animal research for berberine, curcumin, and omega-3s. So I put them together and started taking them, and my appetite is 0 all of a sudden. Fixed. It's like, what? In one day, just thinking deeply. Yes, there's vegetables and resistant starch fibers. Yerba mate does pretty well, but berberine, curcumin, and omega-3 together, it works for me. Can't believe it. Thrilled.
Amazing. Have you tried Amerisate?
No, say it again?
Amerisate.
Amerisate.
So Amerisate is an Australian hops. It's from the hops plant or flower, and they've isolated it and figured out that it will stimulate your own release of GLP, of GLP-1. And so it's a natural, wouldn't call it an agonist, you're producing your own. So it doesn't have as many side effects that we see with gastroparesis and pancreatitis. The other thing I love about it, I use it for my patients that are kind of midway between, they don't really need an injectable medication and they don't want to go down that road, but they just need a little help, right? They want to get through that last couple of hours of their fasting window. And that is a really great measure. And they can dial it in. They can use it when they want to use it and not use it when they don't want to use it. Rather than injecting a shot that's in them for a full week.
A week, yeah.
I use berberine a lot, though. Berberine, alpha lipoic acid I use a lot, chromium. And then I really refer to the blood work to see how much nutrient replenishment they need with the basic nutrients like vitamin D and the B vitamins. And then for some patients, I even do a micronutrient test to really dig in. Me personally, the amino acid asparagine is low for me for some reason. I don't know why. And I replace it. But having that knowledge, I would have never known that if I didn't do the micronutrient test. And so I add that into my vitamin compound. And I haven't repeated the tests yet. It hasn't been a full 3 months, but we'll see if that does the trick.
Oh, let me know how it went. For sure. For sure. Are you an A1C tracker? Do you have A1C targets for people?
Oh, definitely. Yeah. There's actually a really cool chart that I looked at a few months ago that actually showed for every 100th of a point above 4.8, how the risk progresses of developing diabetes and all-cause mortality. And even just to go from a 5 to a 5.8, which 5.8 is a pretty common number you see on people. You're going from a 3 in 1,000 increased risk in mortality all the way up to 12. That's a quadruple increased risk just based on that hemoglobin A1C alone, and one that wouldn't even be flagged at the doctor's office as being abnormal.
Okay, epidemiology, thank you again. I need to look into this. I need to see this because we have been, a little bit lenient on, sort of the numbers below 6.4, just given not knowing the long-term risk and the lifestyle detriment that people have to go through sometimes to lower, especially if they've been up in the 8s and 9s and we've got to 6.4 and felt pretty good about it. Do we go below 6 and how aggressive should we be? Being able to quantify that would make a big difference in my practice. So thank you for that. I'll be checking that out immediately after our call.
Sure, I'll share it with you for sure.
Oh, that would be very helpful. Yeah, because, being able to speak to the objective data, like, okay, if we do this, if we start this fasting routine, yes, it's going to be hard for a couple of weeks. Here's the long-term value, 12 in 1,000 down to 3 in 1,000, and we can do this. Then it can be quite motivating. It also might tell a person to say, they're happy with their choice. That's not a big enough difference for me. I want to eat late at night forever, kind of thing, which it's up to them totally. But I can't wait to see that. So thank you.
Absolutely. Yeah. No, and it's how I show patients too. And I include it on their review, and that way they can see.
Is this something I'm going to participate in? Next we had the uric acid, I think was on the list next, which is a really, really good one. Such an inexpensive test and can tell you so much about how to program your nutrition differently or be like kind of inspire. Is that how you use it? Like, whoa, the fructose here, too much.
100%. People hear the word fructose and think fruit equals good. And fruit is good, but fruit's good when it's whole and it has fiber in it when it's whole and it has skins on it, which are phytonutrients. And so all of these things contribute to the goodness of the fruit. Once you squeeze the juice out of it, first, think about quantity and volume, right? In order to feel full in your stomach from the juice of an apple, you would probably be able to drink a whole lot more juice than just came out of one apple. And so right away, you're consuming probably 5 apples in that little cup your grandma used to have, the little ones. Versus eating a fruit, you're going to be full. That fiber, you're microbiome is going to take that and feed on it and create other byproducts in your colon that are going to be good for you and beneficial for your cells. So when you juice it and you extract that juice, you forget the fiber, you forget the phytonutrients, and you're just getting the sugar. And you're getting glucose plus fructose. And fructose is a way that our body stores glucose, and it stores it as fat. And that's just because of evolution. When we were foraging and we would find fruit on trees, that needed to be stored as fat for when we didn't find food or find an animal to eat. So fructose is really not good. It sounds like it should be good because it sounds like fruit. And, with food manufacturing, we isolate that sweetness and we put it in processed foods. And then we sell that processed food to you and make you addicted to it. So you want to keep eating it. And then that fructose just keeps elevating your levels of uric acid. Mm-hmm. And that's a huge inflammatory molecule in your body, which is no bueno. So, getting out the simple fructose and putting in some fibrous fruits instead of that juice will provide those things. Or for people who don't like fruit, I put them on some phytonutrients. And so the chemicals that are found in broccoli, the chemicals that are found on the outside of an apple can be taken in supplement form.
Vitamin Lab revolutionizes personalized supplements, empowering health practitioners to create tailored supplement formulations that address each patient's unique needs. Bring personalized health to your practice and choose from over 200 professional-grade ingredients to create vitamin formulas that improve patient adherence and result in tangible outcomes. All ingredients are sourced from the world's most trusted suppliers, and Vitamin Lab provides hands-on support to help you formulate and launch personalization to your patients. Say hello to a new era of personalized supplement solutions. Go to getvitaminlab.com/personalized to save $100 off your first formula.
Definitely. I mean, next you took us to nutrient assessments, which of course at Vitamin Lab is incredibly helpful because Vitamin Lab makes custom vitamins, and it's been a huge part of my practice, like actually knowing how we should direct the supplementation. And then custom programming vitamin therapy. And it makes a difference for people. Like, you can really feel a difference when you're getting the right things, especially if it's something that's in the energy production cascade, for use in by mitochondria, then it can make a huge difference, like clinically, quite quickly. The things that get me are the things that are sneaky, like fat soluble vitamins like vitamin D and immune function, and just not being able to feel that or sense it. Like you said with the amino acids, not being able to feel like, it takes a long time to figure out you're not building muscle as quickly as you actually should be. So micronutrient tests can make a big difference for things that are kind of sneaky and quiet that you can't really tell. What kind of experience have you had with this test? I know your personal one is great, but what else have you seen on tests like this?
I found so many micronutrient deficiencies due to medications that my patients are on. The statins really are the most common. I don't know if mainstream cardiologists or internists really get a lot of information from the pharmaceutical reps when they market the product to what they need to replace on patients. And so hardly any of my patients that come to me on a statin come on a CoQ10, and I see so many low CoQ10s in my patients. Or glutathione. Glutathione is one of the most important chemicals in our body for detoxification. If you don't have it, you're not going to detoxify as effectively as you should. It decreases as you get older. And as you get older, especially for women, we end up, a lot of us like me, on hormones, right? On hormone replacement. And I want to detox my estrogen that I'm putting in my body. I don't want it circulating all over, creating bad karma everywhere it goes. And so glutathione is how it's going to get out of me. And so that's another one that I find low on so many people because it naturally just goes away as we age.
Right.
So yeah, I think those are probably the two most common deficiencies that I see that I can correct.
Wow, cool. What other functional tests are you using? Like, what other directions are you going?
I do a lot of metabolism tests, like the Dutch estrogen metabolism test is a big one. I have a lot of hormone replacement patients in my practice. And it's important for testosterone replacement as well. Both estrogen and testosterone have to get detoxed through our liver and then through our GI tract. So I find that test super valuable. And, it's funny because there are a lot of very expensive genetic tests that you can do, like cheek swab tests where you can get your whole genome. But you can find a lot of these things if you look at the way a patient is detoxing. If they're not methylating, the COMT gene probably has a problem, and you can see that in the Dutch test. You can fix that with SAMe as a supplement a lot of times. If you see somebody is going down a 4 pathway on their estrogen metabolism, you might provide them with extra glutathione because we really want to push that in the opposite direction. You can find problems with the bowel excreting once the liver detoxes, which is probably the most dangerous situation you can be in. You've methylated and now you've created a toxic metabolite. How are you going to get it out? Your GI tract better be working. And if it's, if you have a leaky gut and you have other bowel things that are going untreated, or you're not providing your microbiome with what it needs, or you have no microbiome because, you're deficient in probiotics, then you're going to see abnormalities on that test there. So you can pick up a lot of multi-system issues just by looking at how people metabolize.
Mm-hmm. Is bioidentical therapy part of your scope? Like, do you prescribe bioidenticals, or even just HRT in general? You seem to use it a lot.
I do, yeah. I prescribe only bioidentical estrogen and progesterone.
Mm-hmm.
I don't use any synthetics. Testosterone, I do use a lot of synthetic testosterone just because injectable is a lot easier than the cream. And right now the cream is the only option for nasal too, but nobody likes that one.
Okay, Yeah, I'm not familiar. It's out of my scope. Testosterone's out of my scope, so I don't have a lot of experience with it. But the bioidenticals, I'm considering changing initiation protocols, like dosing strategies initially. I'd love to learn a little bit about how you dose bioidentical hormones initially, what types you use, and just some of the dosing strategies that you think are most valuable for people.
For sure, yeah. So I usually start, it depends on the age of a patient. If I have a patient with premature ovarian failure, I'll actually aim a little bit higher because that's a younger woman who would normally have a higher estrogen level. She'll also need it for longer in her life, and I don't want her to be deficient. So I'll usually start at a higher level on a younger woman, on an older woman, starting for the first time maybe, depending on how far she is into menopause. I'll baby step that up. And I really don't use labs that much, only at the beginning to kind of see where I'm at, what I'm dealing with. I follow them based on symptoms, and I can titrate the medicine up or down based on how they're responding. Too much estrogen will typically give you breast pain or a migraine headache. Too little can leave you with brain fog and a lot of mood issues. Too little progesterone, anxiety, difficulty sleeping. So I use symptoms to gauge response. Testosterone, muscle gain, and that's compensatory with the effort you're putting in at the gym. And then as far as dosing, there's all kinds of different methods. There's commercial patches, there's commercial oral progesterone. You can get cream compounded. There's even commercial creams for vaginal dryness. So there are a lot of different methods. I usually, depending on what my patient is dealing with, I'll present all the options and see what fits their lifestyle.
Okay.
Some people don't mind using a cream, and some women are like, "You're kidding me? I'm going to put a cream in there every night." I'm not doing that. And so I find solutions that will be easy for them to just, comply with.
Yeah, individualized. I like that. Do you use a lot of the patches?
I do. They're just so easy. I personally use a patch. I've tried the cream, really wanted to do a combination, estradiol, estriol, when I started my own hormone replacement. And I found that I didn't comply with the cream.
A lot of people end up doing twice a week estradiol patch, pretty common.
Yeah.
But sometimes the dosing I find difficult with that. I find it tricky to find the right dose. So I'm still working on that a little bit.
I think it's hard. One of the downsides I found actually of personalized medicine is I'm incredibly accessible to my patients. I like to talk things through. I consider myself a consultant. I'm not the boss. I'm the educator, and we make decisions together. My patients will share with me a lot of how they're feeling and how they're responding. And so those are really good ways to dial in therapy. Yeah. But I've also learned that too much access, then you're dealing with issues on a day-by-day basis rather than, okay, today I was sad, so do I increase it? But then I got a migraine, do I decrease?
Right.
So that is one benefit, I think, to having more spread out sessions with patients is that they have time to see if the problem is really a problem or just a nuance of the problem. But using those symptoms really does. And the more you work with somebody and dial things and get the finesse of it, I think you learn quickly what's going to work and what's not going to work when you hear that set of complaints.
Yeah, for sure. For sure. Good point. I've got a series of questions that we typically ask on this show just to get a sense of what practitioners are doing to personalize their care. One of them is this one. Tell us something about your practice that you had to learn the hard way, something that wasn't taught to you in school. Do you have an example for us?
Yeah, actually, I think that one was that was probably one of my hardest lessons is the access.
The access. Oh, big time. Don't look at my email box. It's miserable.
I know. Well, I try to respond right away so that it's done, but I also know that kind of usually encourages more emails to come flooding my way. But I think the biggest thing is the lifestyle measures and really how to intervene with food, nutrition, how important exercise is, and how to be the go-between between the book and the patient and really try to kind of pick apart what's stopping them from being successful there. If we could stop having so many diabetics or heart patients, then we wouldn't have so many sick elderly people. Mm-hmm. But until we get that first preventative piece out of the way, we're not going to affect that at all. We can treat a diabetic once they're diabetic, but let's worry about not making them diabetic. And I don't think enough emphasis was put on that in school. And I think that principle is the most helpful principle to my patients rather than the medication I can prescribe them for the disease. And that's always been the missing piece. I had to teach myself so much of that.
Definitely. Oh, that's a great lesson. But now we're doing one-on-one care, right? Like now this education is all out there. All the information is there. Most people know how to eat and exercise, but they come to us for this one-on-one experience. And I feel like it's the same education they could just read about on their own. I feel like it's the accountability. I feel like it's just having that person saying, now you have to do this. This is what this next couple of years is going to be like. You want to build these routines. And I feel like they want to be accountable to someone or to have someone say, to be the parent in the room. But it sounds like you're making yourself available for that. What's that process been like being a part of a team for people on the preventative side?
I think a lot of people leave a medical encounter, and I know this just from working in the emergency room, not understanding, but also being too afraid to ask a question. And they feel like the information is so difficult and so sciencey and so over their head that, well, I didn't understand it, but I don't want to look dumb and I don't want to ask questions. Or maybe they were treated poorly. Maybe they did ask a question and it was answered in a way that made them feel that way, made them feel less. There is nothing that I do that is so complicated my patients can't understand it. I can simplify it to a 4-year-old to understand it. So I think it's a cop-out as a medical provider if we don't take the time to put things into English for people to understand. And as soon as you do that with somebody, it's amazing how people will open up and then ask the questions. And what that does for them, it literally fills their toolbox with a tool that they didn't have before and they will have for the rest of their life and encourages them to seek more of that. A perfect example, I think, is a kid with a fever, right? First-time parent, 2-year-old, super high fever, comes into the ER, and the nurses are like, well, why didn't they just give him Tylenol at home or Motrin at home? Why is the baby in a sweater? The parents feel like, oh my God, I'm the dumbest person in the world for not knowing that. Well, how are you supposed to know that? I will sit down and explain to them, look, fever is normal. It's natural. Give the baby a Tylenol. But don't be worried. The fever will come back. I promise you. In 3 hours, it will come back. Doesn't mean there's anything wrong with your child. It's normal. The virus is in there. The Tylenol was only in there for 4 hours. As soon as the Tylenol's gone, this is going to come back. Connecting the dots and telling people what they're seeing is normal, what they can do to help themselves, and also what they may or may not see and prepare them for that ahead of time. People my patients, I know from the experience, they thank you for that. They love that. And now the next time the kid gets a fever, there is no visit to the ER. You've just decreased the glut in the emergency department just by completing that circle for somebody. And if you do that over and over and over again, for each disease process, for each question about the medication or question about diet or how to progress their exercise routine, you've empowered that patient. They don't need you anymore for that particular thing. And that's what personalized medicine is to me, is empowering my patients with all of these things that are concepts that they do not have to be a doctor to understand, but they do need somebody with that experience to be able to put it into English for them.
Definitely. Now, is this how you would talk to your recent grad PA self? Is this the advice that you would give yourself if this was the first couple weeks of your career, about communication and being there for the person?
Absolutely. Put yourself in their shoes. If I went into a courtroom right now and the judges and the attorneys started talking, I would be so confused. I don't know any of those words. I don't know what they mean. I don't know how they apply to me. Put yourself in that position and realize that that's the position your patient is in. Mm-hmm. They don't know what a UTI means. They don't know what those letters mean. They don't know that they should have, given their baby Tylenol. They just don't know. And put yourself in their position and then listen to them and try to understand what they're saying. And if they're using descriptive words that aren't the same words that you would describe, ask more questions. Be a fact finder. That's your job.
A fact finder, that's your job.
Really vivid.
Perfect. I realize I've gotten this far into our interview today, and I haven't asked you if you have a clinical focus. Is there something in your practice that you see a lot of that, is your favorite thing to be working on, or the thing that people seek you out for?
It's funny. When I started functional medicine, I really, really loved testosterone replacement. Honestly, because it's just so simple and it works and it's so easy to see the effect and it's so fast. But really, my skill set is being a medical detective, and that I think just comes from my background in the ER, making that list of all the things that could potentially harm my patient and systematically going through and ruling each thing out is kind of the same thing I do in functional medicine. And so I really like the big scope. I don't want just to deal with your estrogen or your testosterone. I need to know what your thyroid is doing, what your cortisol is doing, what you just ate last night, how you slept. Are we managing your cholesterol? I like the big picture. And so it's so hard to specialize when you do that because, everybody needs the same comb over, no matter what their problem is. They need a head to toe assessment. And so I don't think I ever want to stop, just really treating the whole patient. And so I think that will make it very difficult to focus into a niche.
Totally. You're preaching to me. This is what I tell the graduates. You have all this training and all this opportunity to think holistically all the time. It's the most fun. It's the best. And you can do the best work, or not the best work, but you do a broad range of things that benefit people in such a great way. You mentioned testosterone therapy a couple times. It's interesting to me since it's outside of my scope. And I have questions that are quite personal. I'm getting to the age where I have to start thinking about, is this something to integrate into my life? Like, when are we thinking for people, to start looking for men especially? When do we start thinking about supporting testosterone levels? How should we determine? People ask me all the time, should I start now? How do we know?
Yeah, so it's funny. If you looked at somebody's labs from the 1990s and you look at that right side of the paper, the ranges that you would see for testosterone were very, very different than what they are today.
Seriously?
Today, they'll put on there the lower limit of being about 200 and the upper limit, I think they put 800 or 900 on there, if I'm not mistaken. And in the 90s, it was more like 500 to 1100. And so over the years, we've noticed a huge decline in the average testosterone number in men to begin with, and in women to begin with. And a lot of that is due to environmental factors, inflammation, chronic disease has been progressing. You're going to see abnormalities quicker. But really the way the low testosterone manifests itself, the most common complaint that you will hear, and it's not necessarily libido, although libido is one of them, is difficulty putting on muscle. Just sarcopenia, people not, going into the gym and working out, but then still having the same muscle build as they had, and they should be putting on muscle. Or low energy, that's another one. Libido is one. But yeah, so those are usually the symptoms that cause people to get checked. And then once you check testosterone, you'll find sometimes the problem actually comes from the brain signal. It's not the testes at all. The testes are ready and willing to make testosterone, but the brain's just not sending the signal. It's like, the manager never showed up for the day, so nobody's working. And so you see that more and more with younger people now. especially head injury patients. And it doesn't even have to be a big head injury. I've even had patients from, we suspect from soccer drills of bouncing the ball on the head. That's not a big head injury. That's just a repetitive movement over and over. But the nerves that connect the area of the brain that produces the signal that gets sent to the testes, they're just fine little delicate wires. And so anything that, traumatizes the head can cause little breakages in those wires, and then the signal never gets sent. And so knowing where the testosterone deficiency comes from, is it a brain-related problem? Is it a testes-related problem, or both, is the first step, because that's necessary to know. If the testes are willing to make it, then all you need to do is provide the brain signal. Mm-hmm. And that's one medicinal treatment. We do clomiphene for that, Clomid, or HCG injections are useful to provide that missing brain signal. And then if the testes aren't making it, and that's what happens, cells, just like any other cell in the body, gets tired of working. And so you don't have as many functioning Leydig cells that produce the testosterone, then we have to give it. And the only way of doing that is you take over and you just provide your body with the missing hormone, either through injections or creams. Nasal sprays are a very unpopular way of replacing testosterone. And then you monitor for symptom relief. I use blood tests to make sure that the numbers aren't super physiological, or that a patient is responding. I use blood tests on patients that I'm doing the Clomid or HCG treatments on to see if there's any response at the level of the testes with them producing testosterone, to decide whether or not to continue therapy or to move on to testosterone. And then I also use blood tests to monitor the metabolites, DHT specifically, and estradiol, because you will lose some testosterone to both of those things through metabolism. And DHT really has a much higher affinity for the testosterone or the sex androgen receptors than actual testosterone does. And so it can exert more effects on the hair and on the prostate. So you want to be cognizant of that while also protecting the libido. And so balancing that number, in my opinion, is actually more important than balancing the testosterone number itself. And then also the estradiol. If you give a man a lot of testosterone and he converts a lot to estradiol, then he could have symptoms like, man boobs, gynecomastia, undesirable things. So, you can't just give a guy a bottle of testosterone and say, go to town. You really do have to be cognizant of what's kind of coming out the back end of it.
Totally. I'm trying to make myself available as a provider to the prescribers here in British Columbia as the person who considers these metabolites and the hormones that are produced from testosterone, because it's being missed conventionally here, because it's physicians and other healthcare practitioners who don't have access to metabolite assessments who are doing all of the prescribing. I would love to be the one to support them. I'm right there with you. I think that's so incredibly important. And you may be able to keep a lower dose if you're monitoring these conversions really, really effectively. But what are the side effects we're looking for in the first 4 weeks? A lot of people come to me saying, I've started this. They just gave me the prescription and then said, come back in a few months. How can I support them in the first 4 weeks? What do I look for side effects?
Yeah, so I think you're more likely to see side effects in patients that are doing large doses, not as frequently. And so, if I have a patient that comes in and they're taking 200 milligrams injectable once every 2 weeks, the first thing I would do, I wouldn't even wait for symptoms. I would back them down and have them split that dose into 2 doses, 3 days apart. Because the effects that they're going to get, you might not see them right away, right? If you give somebody a 200 milligrams of testosterone and it goes into their bloodstream, your blood is going, your receptors are going to bind some of it, and then the rest is going to get metabolized. And so you're in those people, you're creating a huge spike in their DHT as a metabolite initially, and a huge spike in estradiol. And so you're going to see more of those hair loss effects. You're going to see prostate enlargement, not cancer. Testosterone does not cause prostate cancer. We know that. You're going to see, if you have too much estradiol, you're going to see the man boobs. And the problem is you might not see them right away. Usually people feel really great when they first start, no matter what the dose. And of course, the higher the dose, they're going to feel great. And then they're not going to feel so great, when they start to develop all these metabolite issues that go on down the road. But yeah, I think more than anything, supporting people in the first 4 weeks is going to be making sure that they're on dosing on the right schedule.
Sure.
And then the other thing is patients that are on cream, creams are applied daily. So technically those levels are more stable, right? They don't get the peaks and troughs. They tend to metabolize differently. So it's a smoother metabolism. Maybe better for people that do hypermetabolize to put them on a cream so that they're not getting the spike and the peak and trough so high and low. But advising those people on transference is very important, because if they're using the cream and then they're touching, their coffee mug, and then their wife picks up the coffee mug or whatnot, or their dog, so, really counseling on appropriate dosing and on appropriate precautions, I think, are really the best way to support a patient initially.
Oh, for sure. That's really great advice. I've learned a lot from you today, Jennifer. One thing we typically end with is something interesting about yourself that most people don't know. Anything in the spirit of personalization that you could share with us that's unique about you?
Sure. Well, maybe not unique, but I've had 2 big milestones this year. I had my 50th birthday in February.
Happy birthday.
So I've joined the 50 Club. My husband is very happy that I'm now in his camp. Mm-hmm. And I'm in menopause. I had to have a full hysterectomy a couple months ago. So I've joined the Menopause Club, and along with a lot of patients that I take care of. And honestly, I don't mean to brag, but I've had an incredible time with it, because the phase of perimenopause is so erratic. Our hormones are jumping all over the place, and you're trying to balance what's usually an issue of progesterone, cortisol, and testosterone. And once that kind of falls off the cliff and you take over, you're kind of just filling the tank. Mm-hmm. And that's a lot easier to manage than hormones that are in chaos. So I don't know if a lot of my patients know that about me. But yeah, I'm officially in the 50 and in the Menopause Club. So.
There you go. Well, thanks so much for sharing, Jennifer. Tell us, where can people connect with you? How can we find you online?
Absolutely. So my website is noblefamilymedical.com. And as is my Instagram. And there's a booking link on my website. I do free discovery calls with my patients, or I do free discovery calls with my potential patients. And or they can give me a call on my business phone, 323-289-8900.
Excellent. Thanks so much. Well, nice chatting with you, Jennifer. I feel like I learned quite a bit that I can apply in my practice really, really quickly. So I'm really grateful for that. I appreciate you coming on the show, and I hope to see you again soon.
Thank you. So nice meeting you. Thank you for having me.
Talk soon.
Have a good one. Bye-bye.
Thanks for joining us for today's discussion. What about today's podcast resonated with you? Be sure to tag at Dr. David Dizer and at Get Vitamin Lab. If you're learning from and enjoying this podcast, please let us know by subscribing to our YouTube channel and follow the show on Spotify and Apple. And don't forget to leave us a review. It's the best way to support our podcast, and it helps others find us. To learn more or book a demo to explore what personalization could do for your practice, please go to www.getvitaminlab.com/personalized.